this computer. Okay. So, pain diagnosis and management of the emergency dental patient. For those that have been around a few years, these lectures are all based on previous ones, but I realise I can't just repeat them because we need some new stuff. Some of the cases might be repeated, but if you remember them, that's fine as well. Okay, so start off. Before we start today's breaking news, we have a fight between the head of the GDC and the head of the CQC. And we all hate them both. Some of us hate one more than the other. Some hate the other more than the first. But speaking to everyone, we've all got a story. There's no one in this room who hasn't had either the GDC or the CQC or one of the protection bodies or an unreasonable patient or something like that, or the NHS have a massive go at them that was completely unwarranted. We should know that. We shouldn't feel that it's something about us. We shouldn't be ashamed of it. It's something that's happened, and we unfortunately all have to practice in that environment. And sometimes what the gorilla on the left wants is, 100% opposite to what the gorilla on the right wants, and we can't make everyone happy. Okay, so what are we trying to achieve in the emergency dental service? Get patients out of pain. That's the key thing. We want to get patients out of pain. We want to improve patient care. We want to do it as best we can. Evidence-based dentistry is brilliant. Everything should be evidence-based. What's the evidence base? It's not brilliant. And if you really want to be strict, it's pretty lousy. But it's the best we have. And where that's lacking, where we don't have the perfect evidence, or we don't have the time to read every last paper, even if we just pick a few journals, we should follow established guidelines. There are guidelines in emergency dentistry which we can, for the most part, follow. There's a question of what is the place that we can try to innovate in, and should we be trying to innovate? I'm just going to leave that there because I'm not, convinced we should all be trying to innovate. But how does anybody innovate if we're following guidelines? Is a tricky one. Okay, so if you can look at these clinical notes, tell me what's missing. If anyone's not able to see a screen, I'll read it out. Complaining of, number 1, pain lower right quadrant. Number 2, pain upper right quadrant. Attended with husband having travelled by bus. This is actually a copy of someone's notes. I've changed it a bit, but dental history taken, social history taken, medical history taken, and noted upon. Extraoral examination, intraoral examination, gingival examination, dental examination. Investigations, percussion, palpation, pockets, vitality testing. Radiographic justification and report for 2 separate periapicals, one at the top, one at the bottom. The diagnosis, options discussed, including the pluses and minuses of all risks. 2 options, 1, 2, and 3, and the obvious option of no treatment. Advised patient to put follow-up appointment, gave guidance as to what to do if it gets worse, or if there's a swelling or pain, and signposted to NHS website 111 909, etc. So what's missing? Anyone want to shout it out?
Treatment.
The options.
Exactly. Pardon?
The options.
The options, no, the options are there. The options have been discussed. The key thing that's missing is no treatment has been done. This patient will leave with as much pain as they came in with. And we have to somehow or other break this down and try to get through all of the stuff we need to put down whilst actually treating the patient and getting them out of pain. This isn't the note-keeping lecture. The note-keeping lecture's next week or the week after or whatever it is. But fundamentally, we have to remember to get the patient out of pain. And sometimes we have to skip other things in order to do that. That doesn't mean we should skip everything. Joe, for the register with Charlene, there's a few other people watching with it. Okay. Right. Where are the chess pieces? Anyone here a good chess player? Right, you haven't nominated yourself tonight. Okay, so a piece of research shows that if I show that chessboard to an expert chess player for 5 seconds, he will be able, or she will be able, to tell us exactly where the pieces are and put them back on the board in the right place. And if I show it to somebody like me, who occasionally plays with the kids but isn't particularly good, I would not be able to do it. I would need much longer to be able to put that board back together. Why is that? Anyone? The answer is not because the chess player is cleverer, but because the chess player understands what a chessboard looks like. So he will look at that board and say, that's move 17 from the World Championship of 1995, or whatever he might say. And he can put it back together immediately, whereas I can't do that. If we randomly assign these chess pieces to a board, the expert grandmaster will be no better at putting it back together than a person who doesn't know chess at all. When it comes to dentistry, we are experts, and our aim is to try and become, as high up the chain of being a grandmaster as possible. Okay, so what are we doing? We start an appointment off for a pain diagnosis. We need a medical history. What are we looking for in the medical history? Two things primarily: conditions and medications which may make some treatments more difficult or impossible. Knowledge of pre-existing medical conditions in case of an emergency. I mean, that's pretty important medico-legally, or when something goes wrong. And we should start with information we've already got. Triage have normally put something down. The patient will often have sent in the response to the online SMS they get. So they've done a medical history. And then they may already have been in before. And I saw a brilliant one today where the patient had filled in the medical history online, and then the dentist had decided to redo it themselves for whatever reason, coming up with less things on the medical history than the patient had put there initially the first time round. So having spent time to get less than they had to begin with. We need medications and past prescriptions, which can be found on the NHS app. That's a useful tool if someone's got it. And knowing what the medications are is often helpful. Open and closed questions. When should we use them? So an open question is when you say, tell me everything you know about the, and a closed question is, are you on blood thinners? So when do we use them? The open question is, broadly speaking, when we want lots of information. The closed question is we want the patient to shut up so we can get on with it. We just need to know that one bit of information. And it's useful for anything, medical history, dental history, anything else about what's going on. Sometimes the patients will want to tell you everything. Sometimes you've got to listen, sometimes not. Okay, the history of the presenting complaint. When did it begin? Where is it? Is it referring anywhere? Describe the pain, duration of onset, how long has it been there? Is it affecting sleep? Is often a key question. Is that sort of level of how bad it is. Exacerbating factors. Is it worse with hot, cold, biting, opening? Relieving factors, typically medication, but it could be sticking cold water on, it could help. In many cases, we're close to a diagnosis at this stage. But the big important thing I put in capital letters is keep an open mind. And we should go through a careful methodology to make sure we get this right. The dental history, what are we looking for? Attendance, when did you last go to a dentist? How often do you go? That sort of thing. And it may not be that every question is suitable for everyone, but this sort of thing. Have you had treatment recently? It will normally come up, if they've just had a filling done and they're in agony, we can be fairly confident, but not totally right, that that's where it's coming from. Pathway to attendance. How many dentists have you called? Did you call 111? Have you been trying to get a dentist for the last 6 months? Are they keen? Do they want to treat it? They just want to get themselves out of pain once? Where are they at? Sadly, the follow-up care. And I think we've got to treat patients in the world as it is, not as we wish it were. And the sort of thing I'm referring to here is that if, for example, a patient has spent the last year looking for a dentist and in pain and suddenly got to us, and we say, well, look, we could extirpate this upper 7 and then do a root canal filling later on a curved root. But there's no chance they're going to get to a specialist who will agree to see them. If they were going to go to the NHS hospital, the NHS hospital will say this is not a strategic enough tooth and we want it pulled out. Are we better off not taking it out for them at that point? Ideally, no. Ideally, we should extirpate and get somebody to see them, but that's not where we're at. And knowing where the patient's coming from is always helpful. We won't always get it right, but it helps us to advise better. The general examination, extra, look at the patient, looking for asymmetries and things like that, swellings. Nodes. If the nodes are swollen and tender, is that a sign of infection? Or is it a sign that the body's actually fighting that infection? Sometimes you palpate the nodes and the patient actually feels a bit of pain that they didn't even tell you about. Does that mean they've got an infection? No, they're probably just fighting one. TMJ, can they open their mouth properly? This isn't for every single patient, but obviously if it's relevant, if they can't open their mouth properly, you will have noticed that. General state of the mouth and oral hygiene, you don't need to write all this down, but you've got some sort of awareness of whether it's a clean or dirty mouth. Occlusion, management of a tooth is affected by unopposed teeth or high, low strategic value. Strategic value is a whole big question. Some teeth are not worth saving because perhaps they don't bite and they're never going to be of any use holding anything on. And I know that sometimes I'm 3/4 of the way through it and realise, was there any point doing this? This tooth, it doesn't occlude with anything. It would have made more sense if I told them to bite at some point first. We all make mistakes, myself especially. The dental examination. Within HUDC, we're following the American Association of Endodontists protocol. Came out in the autumn or the fall of 2013. If anyone wants this paper and hasn't had it, I'm happy to get it sent to you. Ask Lisa, ask Joe, ask Charlene, Leanne, they've all got it. So we're looking for caries, we're looking for fractures, we're looking for perio disease, tooth wear, quality of existing restorations. We're not necessarily going to do every single thing on every single patient. This does not mean that we need to do a BPE for every patient. It does not mean we need to do full charting either. But these are the sort of things you're looking for. It's nothing new. I'm not teaching anything completely new here. As a general rule, though, every relevant tooth needs to have the following tests done on it. We need to percuss the tooth. We're talking about a patient who's got some sort of endodontic problem, toothache. We've got to be kind to them. Don't whack it too hard, but you've got to achieve the result. There's no point just getting too soft and not getting anywhere. I would tend to go percuss the good one first because that shouldn't hurt. If you get a positive result on percussion, it tends to mean that the periodontal ligament is inflamed. Palpation of the sulcus will often tell you exactly where the problem is. If the sulcus is tender by the 6, it's more likely the 6 is the problem than the 7, and vice versa. Pocket depths, periodontal disease, fractures. And then if you've got really deep pockets, it's worth checking for mobility as well. And endofrost cold test. You can use the electric pulp test if you want. We've got them, but I know they're less commonly used. So pulp testing. A couple of little bits. There was a paper in the BDJ a couple of years back on this. Does anybody still use ethyl chloride? If anyone does, by all means put their hand up and say so. Who was that? Anyone still use ethyl chloride?
I do sometimes.
Who is that?
Asthma.
Boy, Asthma.
Yeah.
I do as well.
Hi, Asthma. Have you not got Endofrost?
No, not in the surgery that I normally work in. I still use
You've
ethyl
got the
chloride.
with ethyl chloride.
Yeah.
I mean, I don't believe it's any cheaper. It's one of these things. It just makes sense to use the thing that's colder. But yeah. Anyone routinely use heat testing? I would see it on these sort of lists of things you're meant to do, but I can't say I've almost never used it. But it's an option, I guess. These tests are qualitative, not quantitative. So it's not a case of, oh, this one's more sensitive or less sensitive, or if you've got an electric pulp test for exactly what the number is, it's a yes or no. The tests are not 100% accurate. The accuracy improves with attention to detail. It improves with redoing the tests as well. So if you do it twice, you're more likely to get an accurate result if you need to. If you want 100% accuracy, don't follow the procedures. You'll be 100% wrong. Again, test a known tooth first with this because it can be quite uncomfortable, especially if the electric pulp test. Sometimes a contralateral tooth, sometimes a crown tooth, because a crown tooth, if you put Endofrost on it, ought to be negative. For Endofrost, dry the tooth. You should use a larger piece of cotton wool with lots of air in it, fluffy, as that keeps it cooler. If you squeeze it up tight, it doesn't seem to keep the cold for long. Likewise, if you use a cotton bud, it doesn't really keep the cold long. If you're doing small teeth, such as lower anteriors, a plastic strip between the teeth can be useful, so you make sure you know you're only getting one tooth at a time. For the electric pulp test, dry the tooth and wet the ground tip, which is on the lip, the metal thing that you put over the lip. And yeah, the air spray does not count as a pulp testing device. Now, do you need to do it on every tooth? Every relevant tooth. If you know the tooth root treated, it's probably a waste of time, but then I would do it on the tooth next door to check what's going on. Other tests. Biting and opening from biting a cotton wool roll. If it hurts to bite the cotton wool roll, it tends to indicate a problem with the periodontal ligament. If they bite okay and you bite really hard and then they open and instantly get pain, we're looking at a crack in the tooth.
He asked me to open the door, but somebody.
Okay. Frac finders. Adrian, do you have a frac finder in Stevenage? Tooth sleuth.
You bet. I find them very useful because you can also do it. It's certainly for fractures. You can do each cusp individually. Certainly for molar teeth, and it does help. So if you've got a couple of teeth where there's no problem, then one tooth where you get a distinct, then you really feel more comfortable as a fracture. Because otherwise, fractures are quite difficult to diagnose. I'm still nervous about it.
There are people that say you should never use them because they might break the tooth. Okay, I get their point. I do use the frac finder from time to time. It's not every day, but sometimes. Transillumination, again, that's one that's on the list. I mean, I guess it's get your light and shine it at it, and maybe it'll help you see a crack. Again, I presume nobody's using that every day. Selective local anaesthesia sometimes can be helpful. It's usually, though, as a plan to actually treat something. Test cavities. I do these from time to time where I've got a tooth that I think is non-vital. Well, I'll drill into it and we'll find out for sure. Improved vision. Illuminated loops, definitely worth getting. If you're able to. Microscope's even better, but it's not really practical for everyone to start using one of those. Any others? Anything else anyone does routinely or occasionally to help make a diagnosis? I was wondering if everyone was going to shout out the same thing or something.
Scott, one thing I would diagnose is I was going to mention it towards the end, but you talked about a medication about trying to find out what's going on. And I would do look at the medical history. If somebody's got neuralgia or they've got some sort of mental health condition, I am very, very, very cautious. We've all had our mistakes. I had a good friend who came in, didn't do a medical, swore that one tooth was paining him. And I mentioned the root canal tooth on that tooth, and I don't think I should have in reflection. A couple of weeks later, he turns up in pain again. I said, I know you. I'm not going to do it. It was take some antidepressants, which I found out in the meantime, and other things go on in his life. And I said, I'm not going to take that tooth out. And I didn't. And eventually, he pushed me to do it. And I took the tooth out and I put it down and it split in two. So, yeah, just if you don't know the answer, don't feel you have to go there, especially emergency patients where you don't have a history with them. You don't know it. So if you don't know, you don't know. And I'll always back you up on that. Just do the test. If you're still not sure, then let's be careful. In particular, Endofrost, I know Scott likes it. I'm very cautious with it. I've had lots of false positives, negatives, and everything in between. So if you don't feel comfortable, don't do it. But just make sure you've gone through everything. It looks like you've checked out the patient. You've had a good look at them. And if you're still not sure, either call a colleague. I've certainly had Bedwell, you can call me in. Or if you're not seeing them again,
there's a rota of people to call at all times. It's me, Adrian, whoever it might be. Unless you're doing the 3 a.m. shift, you're welcome to call us at any point. Sometimes it's Hummer. Are you on the call, Hummer? Okay. And if for second opinion. But yeah, if in doubt, don't treat. We'll come to that. Thank you for bringing it up, though.
Sorry, Scott, I wondered, how do we know who to call then on any particular session? Is it just you if I'm in your surgery, or is there actually a rota? Because I wasn't aware of that.
There is a rota. So ask who's that was asking the question?
Asthma.
Yeah, ask Joe to give you that rota. As a general rule, it's me, but it's not always me. I'm doing it about 4 or 5 days a week. Friday, Saturday is normally him. I think Sunday is normally Adrian, but there is sometimes where someone's off or whatever. There is a rota that Joe puts out each month, and if you want to have it, by all means have it. But she may print it out somewhere as well.
Yeah, Bedwell ours is in the HUDC folder. The nurses know where it is. If anybody needs to call upon anyone, it's in the front of that folder, updated every month.
Is the one at Rickmansworth in that folder? It sounds like a good place to put it, but Lisa, is that available in Croydon fairly easily as well? The other thing is, if you call somebody, you don't get through to them, always try someone else. It's not a problem. Okay, radiographs. The Americans say we need to take at least 2 periapicals. As far as I can gather, in the UK, the plan is as low as reasonably practical.
So just a moment, Scott. Remember this, we're doing extra slots, and most places have at least another dentist working parallel with you. So by all means, go and ask a colleague. There's no shame in that whatsoever.
Exactly. So I mean, that's an easy one as well when there's 2 dentists or 3 dentists that you can all, help each other. Almost every emergency patient requires a radiograph. It's not 100%, but it's most of them. Rin holders, again, this is pretty straightforward stuff. Gutta perca in the sinus. If there's a sinus, stick some gutta perca in it. It'll help you make sure you get the right tooth. It isn't always the one you think it is. 2D images against 3D images. Does anyone here use CT scans often? Okay, so when you do a PA of a tooth, it will show an apical area, and that's the one I've got to go for. Nice big apical radiolucency. That radiolucency means that the bone has been eaten away and the cortical plate has gone. If the bone is being eaten away but the cortical plate has not gone, you will not see that on the X-ray. And sometimes when you take a 3D image, so you're now looking, instead of from buccal to lingual, you're looking from mesial to distal in the tooth, you will see a very large apical pathology that is just not visible on the flat image. I would have liked to have got some pictures of that, couldn't find one easily yesterday. So basically, and the X-ray does not prove the negative. It confirms a diagnosis sometimes, but it doesn't prove a negative. You can't say, oh, I couldn't diagnose anything because I couldn't see anything on the X-ray. Well, do the other tests as well. So what are the different diagnoses? We have the pulpal diagnoses, what's going on in the pulp, and then we have the apical diagnoses, what's going on at the apex. They're 2 separate things. Exactly how you record it on the drop-down list, we'll talk about next week, but this is about how to make that diagnosis. We start off with normal. The pulp is normal. We don't get a lot of those, but we do get some. Sometimes your patients, have just happened to phone at the right time and been given an appointment, even though there's not a lot wrong with them. Reversible pulpitis, the discomfort goes away as soon as the stimulus is removed, and it's mimicked by sensitivity, which is not a disease in quite the same way. Systematic irreversible pulpitis. They have got symptoms, but they are subjective. Some of them are objective. It may include sharp pain, hot and cold, which lingers, and it's an unprovoked pain. It's there a lot, and the painkillers don't work anymore. It's hurting. Asymptomatic irreversible pulpitis. There's no symptoms, but the dentist feels the pulp is beyond healing. We've got caries into pulp, for example. Not what you normally see on the emergency clinic, but you see it in general practice all the time. These terms need updating, as irreversible pulpitis is now reversible. That's the Biodentine seminar for those. I think it's the last one in the series. Pulpal necrosis. The pulp is dead. It shouldn't feel cold or hot or anything else. That doesn't mean it doesn't feel any cold or hot or anything else, but it shouldn't do in theory. Then we've got previously treated. It's already got a root filling in it. Or previously initiated treatment. Someone has started root canal treatment but not finished it. Usually speaking, it's accompanied with a temporary filling, but I've seen this on patients that have got a crown. So someone started a root canal filling, given up on it, and put a crown on anyway. You sometimes see it that the top of the pulp chamber looks a bit odd, and that's often what it is. So apical diagnoses. Normal, so negative reaction to palpation and percussion. And there is a normal laminal dura on the X-ray. So everything about it is normal. Symptomatic apical periodontitis. This is inflammation. It's a painful response to biting, percussion, palpation. The X-ray may appear normal due to the early stage disease and the 3D effect we spoke of a couple of minutes ago. Asymptomatic apical periodontitis is inflammation. There's no symptoms, but this is where you got the radiographic apical radiolucency. So it's the one you take an X-ray or something and say, oh, or an OPG, oh, there's an apical area there, didn't know about that. Again, you don't tend to get it on the urgent clinic. Chronic apical abscess, little or no symptoms. You've got the sinus tract. take the PA with Guttapercha in it. And again, we do see these on the urgent clinic because the chronic one can go acute at any point. Condensing osteitis, a diffuse radiopaque lesion due to a bony reaction to low-grade inflammation. Unusual, but we do see it from time to time. And then the one we get a lot of, acute apical abscess. It's an inflammatory reaction to pulpal infection and necrosis, rapid onset, spontaneous pain, extreme tenderness to pressure, pus formation, swelling of adjacent tissues. The X-ray, as we said before, may appear normal. Apical abscess does not usually require antibiotics. All the previous stuff definitely doesn't usually require antibiotics. There may be malaise, fever, or lymphadenopathy. How many people are checking for fever now? Do you check it at all? Okay.
I do sometimes check the foreheads, but if you were coming from the cold or just run up the road, they'd be hot and sweaty anyhow, or sitting in your surgery and they're nervous.
It's not, I wouldn't take it on its own, but it's sometimes a useful tool to add in there. What I tend to do when doing it is we will use the forehead thermometer and we will put it on myself, the nurse and the patient, because I don't think they're very accurate, but it means that if we're all high, then as long as we're close to each other, that's fine. If we're all low, the same. But if one of us is different to the other two, there's a question. Obviously, as Adrian says, if the guy's just been running in or it's freezing and he's just coming from the cold, again, he's going to be different. Management. What are we doing with these things? So you've got 30 minutes to solve the problem, get them out of pain. This includes the time taken to make a diagnosis and to write the notes. One of the talks is about this time management as well. We're aiming to get them out of pain or reduce the pain. And we've got to remember that often our patients nowadays cannot access care afterwards, and that is sadly something we do have to think about. We've got the necessary care slots, so don't forget, where necessary, we can book people in. That doesn't mean don't get them out of pain and hope they come back next time to not get them out of pain, and then eventually after the third attempt someone treats them. But if they've dealt with one problem, you can bring them back for the next one. One of the talks we'll talk about that in more detail. Aim for definitive treatment where possible. So pre-COVID, I would have quite happily extirpated a completely hopeless tooth to get them out of pain. So go find a dentist to pull it out. Now, if I possibly can, I want to take that broken tooth out if it's not fixable. Aim to treat the nervous patient. The guy's had pain. He's had a lot of pain. He's nervous. He's even more nervous because he's got pain. He's never met you before. You've never met him. But that doesn't mean we should not be trying to treat him at all. We should look at evidence. What's the evidence for treating patients? The evidence is treatment works. There are no magic pills. I think you might have heard me say that sort of thing before. So how do we treat nervous patients? We all do it. We all know how to do it. But just some points. Be empathetic. Understand them. Be methodical. Follow the plan. Make sure you're taking all the tests. Make sure you know what you're doing. Be confident. Sometimes you've got to tell them this is what you need. I know it's going to be a bit uncomfortable, but I want to help you. Don't confuse the patient. If you take somebody and give them 25 options, we'll all be nervous. Nobody will want to do anything. You've got to hone in on what actually needs doing and try and make sure you get them numb. That helps. Articaine, infiltrations, lignocaine, ID blocks, maybe both for some people. So reasons not to use antibiotics. And again, I think one of the later talks will talk about the antibiotics in more detail. They don't work for the presenting diagnosis. So a patient comes in, can I have antibiotics? Well, I'd happily give you them if I thought they'd work for this disease that you've got. But the condition you've got, it's not going to help. Very few people will ask me because I perhaps show confidence that they don't need them. Antibiotics can create resistance in that individual. They can create resistance in the community. Allergy, stroke anaphylaxis. C. difficile infections. This is where the antibiotics knock out everything else in the gut microbiome, resulting in severe infection by C. diff, which can be very difficult to treat. you've not got a leg to stand on if you prescribe that inappropriately. So we know that very often complaints will come in saying, dentist didn't give me antibiotics, I wanted antibiotics. And you can defend it. It's a pain in the neck when they do that. But if your notes are good, the diagnosis is, I don't know, irreversible pulpitis. I didn't give you antibiotics because you didn't need antibiotics. Now, sling your hook. If you prescribe antibiotics where they are not needed and something goes wrong, it's very much harder to defend. We've spoken about the gut microbiome, which I think is a big thing coming, in the future. The oral microbiome is something people are talking about. This is where we don't have one bacteria, we have many. Some are good, some are bad, and we're all different in what we've got. Antibiotics knock these things out for quite some time. The HUDC clinical governance program. If you give out too many antibiotics, you're different to what is normal. Myself, Sarah, Hummer, we're looking at this sort of thing. We've got the software looking into it as well. We do want you to be treating patients where, obviously some people need antibiotics, but most don't.
May I just add to Scott's point is that we also give reports to the our bosses, the ISCB. It's something we are quite proud of. We're not trying to get anybody, but we report, and Scott in particular report quite hard. The NHS gives you, used to be 15 minutes, now 20 minutes for, and we've pushed it up to half an hour. So, and we're quite clear about what we're doing, what we're trying to do. So we need to show evidence of it. So it's not a matter of trying to get somebody, but we all know if you want to just give antibiotics, you can do that in 5 minutes. So we push for the half hour, and we have to sort of give evidence that we're using that time wisely, if you like, rather than just cracking on to everybody. Do everybody in 5 minutes.
In terms of the antibiotics, when we first started in 2008, the first day we worked, one of the dentists saw 14 patients in 1 hour. 13 of them got a prescription for amoxicillin and metronidazole, and one of them got a sharp tooth stone. So at least he was awake, but 14 patients in an hour is pretty impressive going. But if all he's doing is giving antibiotics, he could have probably got in twice as many and not wasted time pretending he was actually looking at anything. Perio problems. So the periodontal abscess. What's the prognosis of your tooth? That's the first question you've got to answer if you've got a perio abscess. I'm not going into the details of what a perio abscess is, but we all have been taught that and probably forgotten it and remembered it a few times already. If the tooth is hopeless, you've got to recommend extraction. The problem is, what happens if the tooth's hopeless and it's a bridge or an anterior tooth and the patient doesn't want it out? Okay, it's a different story. But we're aiming to, if it's a loose upper 7, that's got no bone around it, take the thing out. Antibiotics are only indicated for periodontal abscess if there's systemic spread. So if it's an upper 1, there's no systemic spread and the patient doesn't want it out, the antibiotic is not indicated. Clean it out, do what you can, tell him to find a dentist who he trusts who's going to take it out, tell him to take it out. ANUG. And I've seen cases of this recently. You go for a glut of them sometimes, but it's not that common, but it's not uncommon either. Scaling under local anaesthetic is the treatment of choice. Get them numb and get it a bit cleaner. Mouthwash, chlorhexidine, hydrogen peroxide, painkillers, salt water maybe, but I usually go for hydrogen peroxide. Antibiotics indicate only a systemic spread. There are some that say if the patient's coming back and they've had it treated once with scaling under local anaesthetic and mouthwash and it's still there, then antibiotics might help and it will be metronidazole. But certainly it's not first-line treatment. Pericoronitis, irrigate under the operculum. What does anyone use? Anyone want to shout out what their first choice is on this?
Chlorhexidine.
Chlorhexidine, yeah. Anyone worried about anaphylaxis of that? I'm not massively, but it does exist. You could use saline. Chlorhexidine is what I tend to use. Ultrasonic irrigation. You could, in fact, you're just using water and sticking something under there. Anything helps, I guess. You can extract the opposing over-erupted tooth. That would help. It's not always possible, but it's sometimes possible. Sometimes you could just trim it down a bit, at least it would buy a bit of time. Again, antibiotics only indicated systemic spread. severe trismus. That doesn't mean they can't fully open. It means they can't open really at all, or obviously fever, malaise, and whatever are the other ones that we've got already. Post-extraction pain. Take a radiograph to confirm the root is fully removed. The number of times you take one and find half a tooth still there, or on one occasion from a particular dentist who vanished to do implants somewhere, Adrian, who we both know well, I found the end of the luxator in there, which was quite comic, but yeah. A dry socket is not common. It's actually quite rare. Most people have got post-op pain. So, anaesthetic, clean the socket out using a Lucas curette. Have you got those in Stevenage?
I have to say I've never used one.
Okay, so perhaps not. Okay, it's a different story, but perhaps we should, it is something worth having. They're not a big, difficult item to get. It's basically a big excavator. Have many people used these? Is it something people tend to go with? Fair enough. I mean, something you take a tooth out and you've got a big granuloma attached to the top of it. Sometimes. Other times you take the tooth out, the granuloma is still there. If you clean that wound out, it'll heal up a lot better. Less chance of cyst formation, but also quicker healing, less bleeding. Alpha-Gel, this is the stock thing to use. Analgesics, so painkillers, smoking cessation, vaping cessation. BDJ has been hot on vaping recently. We know it's not healthy. Is it as bad as smoking? Maybe not. But it's not something we want to be encouraging people to use. But if it gets them off the cigarettes, it's a start. But stopping smoking is difficult. Antibiotics, again, only indicated if we've got systemic spread, fever, malaise, significant swelling. And again, if you irrigate and clean that socket out, you'll often find the swelling goes down. Bisphosphonate-induced necrosis of bone. Anyone seen a case of this? No? Okay, well. Right. There was an article in the BDJ in November. If anyone's seen this, but it talks of pre-existing medication-related osteonecrosis of the jaw before dental extraction. What that means is to say that the necrosis is there before you took the tooth out, potentially. And they showed a number of cases. And I have seen cases of necrosis. I've never seen a really bad one where the person can't be treated and is losing their jaw for it. But I've seen cases where there's been failure to heal for quite a few months and bits of bone splintering off all the time. Pardon? Okay. And when I've thought back of it, I thought, yeah, you know what? Maybe this one was actually there before we started with them. The signs and symptoms were a little bit weird. It wasn't a classic abscess. And it could well be that the necrosis was there, that causing the pain, causing you to take the tooth out, rather than the extraction causing the necrosis. Because if the extraction caused the necrosis, you can guarantee that the Dental Law Partnership, the CQC, the GDC, and all these other you-know-whats will blame us. Sinusitis. Acute sinusitis, which is what we tend to see, is my favourite diagnosis for dental patients because it means we have to do anything. Analgesics, decongestants, inhalants. Stick your head over a bucket of steam, put something you like the smell of in it, and breathe in deeply. Antibiotics are only indicated if there is systemic spread. They don't need antibiotics for every sinusitis, even if their doctor does think they need it. Their doctor's doing the same thing as dentists that give it out for every toothache. Extended sinusitis going on for a long period of time is a different condition. It's not what we're dealing with. Other causes of pain. Keep an open mind. This is the one Adrian was talking about with his case before of the person with mental health issues. If the diagnosis is not known, you cannot treat. If the diagnosis is known, you cannot prescribe antibiotics either. Now, there may be a case where you can see they've got an infection, they've got swelling, they've got malaise, they can't open their mouth properly, and you can't tell whether it's the 6 or the 7 that's doing it. okay, you've got a diagnosis, you've got acute apical abscess leading to systemic infection. You know, yes, they need antibiotics, even though you don't know which tooth is actually causing the problem because you can't examine properly. Analgesics. Was there another one on that previous slide? No, okay. The other thing I was going to mention comes up later. Okay. Analgesics. The BNF says dental pain is best treated by local measures. We're surgeons, not physicians, although we do both. And for prevention, we become physicians. But for this sort of thing, we're surgeons. Paracetamol, ibuprofen are the best painkillers in conjunction with each other for dental. And there's a lot of good research on this. Paracetamol, 1,000 milligrams 4 times a day. And that's 2 standard tablets. Ibuprofen, it says up to 600 milligrams 4 times a day, which is 2,400. Profstire gives 800 3 times a day. But, you know, going with both, there's an argument, I think, about whether you tell them to take both at the same time or you tell them to take one then the other so they're staggering it and they've always got a painkiller they can take. Obviously, patients that are children or have got, you know, major other illnesses, you might need to lower these doses. Opioids, very rarely indicated. I'm not particularly worried about addiction, but there isn't a lot of point. They don't work any better. It's just sometimes people like to prescribe, oh, take this, it's going to work better. The endodontist for severe endodontic pain will start giving out steroids. On one occasion, on the advice of a specialist endodontist, for one particular patient, I actually prescribed suppository steroids, which I thought was a bit different, but it isn't the first line medication for post-operative pain.
Scott, just one point. On the ibuprofen, just be aware that on the package, I think for ibuprofen it says maximum is 4. It's not 2,400. I think they drop it. I think it's 1,800.
Yeah, correct. I'm going off the BNF there. So I think Livia would go even higher, but the BNF is a pretty authoritative source.
Absolutely. So I mean,
packaging. You know, that said, ibuprofen you can buy in 101 different doses, so you just have to tell people look at the packet, unless you're certain of exactly what they're taking. With paracetamol, it seems to mostly come in 500s or 250 for kids.
Yeah, for ibuprofen, it's 1.2 grams. It's 1,200 milligrams, and we're suggesting 1,800. I tend to go for ibuprofen. There's less liver toxicity, so I tend to go for the ibuprofen.
Yeah. I mean, maximum dose only if required. Okay. Reversible pulpitis. Remove the caries. So this is the treatment. We can argue for that for the next 20 minutes, but we've only got 15 left, so we're not going to. Exactly what does remove all the caries mean? I think the one point I'll say is anyone who's qualified more than a few years, it's less than we used to. It doesn't mean leave a load of soft mush behind, but it doesn't mean get the thing bright yellow with a red bit in the middle. Fuji Equiforte is a glass hybrid restorative, and it's indicated as a long-term restorative material for class 1 and class 2 cavities. The amalgam phase out is happening sooner than we think. If anyone wants to stay on at 7 o'clock and discuss this, I'll happily do so, because I'm interested as to what anyone's thinking is on this. Has anyone given it much thought? Okay, if anyone wants to stay at 7 o'clock, we can discuss this. It's nothing to do with out of hours work or emergency work, but it's interesting. Okay. Irreversible pulpitis. This term is obsolete, as I say, because of biodentine, but most of the time we are not using biodentine for most patients. And for some patients, it is beyond biodentine's help. The conventional treatment is access to pulp chamber and coronal pulpopathy and coronal pulpotomy. And if you've got time, full pulpectomy. So ideally get to the apex. If you haven't got time, okay, don't get to the apex. But the idea that you only have to go halfway isn't really true. And, you know, yes, there are people that claim it and there are courses that say it, but the evidence I don't think is great. If it's a hot pulp and you can't get in very well, that's where you consider Ledamix. I'd consider more anaesthetic or telling the patient to hold on tight as well, but there's a case for Ledamix here. And this is the only good indication for Ledamix. In any other situation, use calcium hydroxide. But if it's really painful and you can't really clean it out properly, Ledamix could be good. Apical disease. Access the pulp chamber and full pulpectomy. And if you're short of time, go coronal pulpotomy. So it's the opposite of the other one. If the problem is just in the pulp, we ideally get to the end, but if you're short of time, you know, okay, just go halfway. Here, we get to the end, and if you're short of time, we go halfway. Yeah, ideally we get to the end. It obviously depends how open these canals are, because if the canals are wide open, it's much easier. If they're not. Dress with calcium hydroxide. Incision and drainage of a fluctuant swelling. Sometimes you do both, incise and drain, and then go through the pulp as well. And when you drain of something, you see the swelling go down, the patient feels better immediately. Antibiotics are only indicated if local drainage is not possible and systemic spread. I saw a patient last week who had a big abscess and the tooth needed to come out, and they got antibiotics. And the only reason they got antibiotics is because it wasn't my clinic and I wasn't in charge and wasn't telling the person who got to decide what to do. But that patient will have had another week of pain before they come back for another appointment to get that tooth taken out.
What about all these
which, you know-
what about all the immunocompromised patients?
If a patient is severely immunocompromised, then antibiotics come further up the list. If a patient is mildly diabetic, hardly. But yeah, you've got to, you know, the rules, the guidelines are guidelines. It doesn't mean you should always never give an antibiotic to a patient. But if you've got a patient who's got a swelling, you take the tooth out and it drains away straight out. You get a load of pus come out, you see their face goes down. There's no reason to believe that that patient needs an antibiotic. If you've got a patient who is immunocompromised, you know, to a fairly high extent, but not so immunocompromised that they're not allowed out in public, and you've taken the tooth out and the swelling's gone down a little bit, but not very much, yeah, I would probably follow up with an antibiotic, because we are concerned. But we have to be aware that those people also have all those other side effects, and we want to be careful that we don't overprescribe. In the
No, I
out of
agree,
hours where
I
we haven't
agree,
got
yeah.
follow-up, we're more likely to do it. Don't forget, we are trying to call all the patients a few days later if you're giving them an antibiotic.
Yeah,
We're not
I am
perfect on
aware
it,
of
we
that.
never
We're
will be.
following the guidance. I'm aware of that. Thank
Yeah.
you.
We try to. But of course, there are people, you know, who need an antibiotic. So fever, systemic swelling, significant swelling which can't be drained, and malaise. So a tiny bit of swelling on pushing there does not really indicate an antibiotic's required on its own. Each case on its merits. Be aware of sepsis. This is critical. Read those posters. They're up on the wall everywhere, the red posters. If somebody has severe pain and they can't be treated and everything's really terrible and they think they're going to die and they haven't been to the toilet for ages, think sepsis, call 999. But sepsis is difficult to diagnose. That's the whole point of it. It's the whole problem with it. Clinical cases. We have 10 minutes left. Okay. So this patient complaining of pain lower right 6 for the past 3 days. It's getting worse. The painkillers are no longer helping. It's affecting their sleep. It's worse with hot and cold. There's a large carious cavity that you can see. It's not TTP, and here's the X-ray. So what are we looking at? This isn't the most difficult case. Pulpal diagnosis. Anyone want to shout it out? Okay, you will
Yeah.
shy.
Irreversible
Sure.
pulpitis.
Symptomatic irreversible pulpitis, correct. Apical diagnosis is normal. There's nothing wrong with the apex there, maybe a little bit wide PDL, but there's, you know, the problem is in the apex. So what are we going to do? I copied this from a slide from a few years ago, and the plan was, well, you extirpate it. Maybe we're talking about biodentine. Maybe. Are we talking about an extraction? Maybe. Personal preference, depends on the patient. Depends, I guess, what the 3D thing is on that tooth, how much tooth is actually left mesially. Anyone want to prescribe antibiotics? The answer is no. And it doesn't matter how immunocompromised the patient is. This patient does not need antibiotics. They haven't got a disease that's, you know, any infection. Okay, the next case. An 86-year-old lady. She's on morphine for arthritic pain. I've got to move that out of the way so I can see what I've written. She's got pain lower left 6 affecting the sleep. She's not. The pain is not affected by hot or cold. The lower left 4 mildly TTP. So it's TTP, but only mild. Normal reaction to endofrost. And again, you could put question mark, yes, no, don't know, not sure. If from Adrian's case, it's not sure. Is it positive? Is it negative? I don't know. There's no deep pockets. The sulcus, I presume, is normal. I haven't written that down there, naughty me. She's got a complete denture at the top and the partial denture at the bottom with 6 teeth present. She wants antibiotics or an extraction. Previously always had antibiotics. Previously always had an extraction. That's why she's only got 6 teeth left. And here's the x-ray. What are you seeing? The answer is, I don't think you're seeing anything. I think it's normal. She's got pain, but it's not necessarily due to any obvious disease. If I take that tooth out, she's 1 tooth less. I might cause all manner of other problems. What does she need? Reassurance. Come back next week if there's a problem. Call 111 again if there's a problem. But it doesn't need to come out. Management plan, certainly no antibiotics. That's not going to help anything. Maybe recommend analgesics. Randomly prescribe fluoride varnish or fluoride toothpaste or whatever you like, but it's some sort of placebo, really. You want to prescribe a placebo. And review it in your own practice, review it again next week. But in this situation, it's 111 again if there's a problem. Okay. Conscious of the time. This is the Bible for our service, the antimicrobial prescribing for general dental practitioners, produced by the Faculty of General Dental Practitioners, now the College of General Dentists. 3rd edition 2020. The majority of infected swelling of dental origin can be treated by removal of the source of infection. Antimicrobials are only indicated as an adjunct if there is elevated temperature or evidence of systemic spread. Scottish Dental Clinical Effectiveness Programme, this one's available online as well. It's 11 years old, but it's under review, so there might be a new version coming out soon. Pulpitis, do not prescribe. Other guidance from this group: caries management, bisphosphonate patients, bleeding, I think they're produced, drugs they're produced. There's pretty good stuff out of the University of Dundee. A guide to good endodontic practice. I think this one's probably worth everyone reading. It's 80 pages. It's available online. It's an easy read. It's published 2 years ago by the British Endodontic Society. The 3 Ds is something they talk about: diagnosis, definitive dental treatment, and drugs. Attempting to treat any diagnosis without first obtaining an accurate diagnosis is likely to result in failure. Antibiotics should only be prescribed if there are signs of spreading infections such as facial or neck swelling, systemic infection, or, as Peter said, for an immunocompromised patient. And for all of these things, how big is the swelling, how big is systemic infection, how immunocompromised is immunocompromised. But that's why we are clinicians and not robots. We have to think each patient through on their merits. Okay, thank you. Our next seminar is next Wednesday at 7 o'clock. Record keeping, including the diagnosis and treatment drop-down list. Anyone know where this is? No, good. Didn't think anyone would. This is a nature reserve in Boston in Lincolnshire, which those who know me will know I have had cause to visit a bit recently because my son's there. Okay, anyone got any questions?
2 points, if I may. I would say, I know you're keen if it's a root canal tooth which could be root canal treated or extracted, and if they haven't got a dentist to take it out. I'd make sure your notes are pretty or more extensive, where there is a possibility that somebody can question on you. I've been on a course where I had a GDC man who put up an X and said, why didn't the guy offer root canal treatment and crowns? Because there's not much of the coronal tooth tissue left there. So I do try and put some more chat down. Just make you aware that the Eastman has guidance or what they regard as being, has got predictable long-term survival is their buzzwords. And they say, the tooth has to have 3 millimeter high supergingival dentine on 70% circumferentially. Well, that's anything with more than an MOD they think needs to be bin. I do make it clear there's not much supergingival tissue. I do put that in the notes. So from next year you can't quite see. And then I would be happy to take it out. But I do put a little bit extra chat in there if they're not going to be if you are going to be taking it out. And lastly, in the notes, if you get in, Scott likes all these drop-down menus and everything else. The slam dunk is if you get into a tooth and there's nothing there, it's necrosis, please put it in the notes. That makes you, it proves that you were right to start root canal. I mean, ultimately, there's nothing notes, but I went in there and there was nothing there, then you're correct to start doing root canal or you know, to go in there. So do put it in. I've a couple of cases, all the notes are there, but they haven't put what they found when they do go in. That's me done.
Anyone got any questions or any points they want to raise?
Yeah, I wanted to ask, patients, I've had a patient who was on chemotherapy. So when they come in pain and they need treatment, for example, an extraction, then if they are taking the chemotherapy drugs or anything like that, how to treat that? Because sometimes we're not okay to treat while they're having their chemotherapy, and then we don't have access out of hours to speak to their oncology team and all that. So how would you
Yeah,
manage that?
It's a difficult question. We need to know, what are they taking? What does their doctor think? Sometimes these patients are very clued up. They've already spoken to the doctor in advance, which is great. But other times, let's assume we've got a patient who, I'm on chemotherapy. What are you on? I don't really know. What's your cancer? They should know what their cancer is. But it's difficult to do anything. We don't want to give medication because that might muck things up as well. And we don't want to do surgery because that might muck things up. The answer is we need to try to contact their specialist. And sometimes the answer is, look, we can't get this dealt with now. We're going to spend our time trying to work this out. Find out what the dental problem is so we know what the treatment we're recommending is. Sometimes it might be a patient that needs an extraction, but we're going to extirpate it until such point as we can extract. If you can't deal with it there and then, it's find out what the problem is, find out how to speak to their doctor. And it may be that you're going to do that the next day. It may be that you're going to ask, I see Leanne or Joe or Angie or Lisa to look into that the next day and get the patient booked back in again. And that's a patient we would happily see twice and get it sorted correctly. But it's not a case of, well, here's some medication, go away, because that may also muck things up. And we've got to be careful both ways. In a serious emergency situation, you can contact the local on-call or surgery team. But again, they may not be able to help you massively either. But there should be somebody somewhere that can help. It depends how serious the problem is. If there's anyone that works in the hospital service that can answer that any better.
I can, Scott, talk as a cancer patient. All cancer patients are given, while they're going on chemo, they're given an emergency number to contact the oncology team.
Okay.
So they should have a yellow card, which they can contact their oncology team and they get back to you. They should be,
Okay.
yeah.
That's really good to know.
And they can contact the oncologist. It might take some time to get through for the answer to come through, but you will get an answer. As far as my treatment was concerned, it was mainly extraction because of bisphosphonates is meant to be avoided. But other than that, everything else is fine. You can have it.
Okay.
So generally, it'd be try and avoid extractions, but extirpations are less likely to cause a problem.
Yes. And not everyone is on bisphosphonates. So, but a lot of us are. Yeah.
Okay.
And
Thank you.
also, these patients are immunocompromised, i.e., they're neutrophils, and so you don't want to leave them for the infection to spread, because when it spreads, they will end up in hospitals, admitted.
These are people that you've got to work out what it is. You've got to try and deal with it quickly, and those two don't always go hand in hand. But certainly, it wouldn't be to tell them to go away. It's not to randomly prescribe. It's try and get an answer as quick as we can and offer them another appointment if we can't deal with it there and then. We don't get a lot of these, and if they come up in Croydon, we've got an in-hours service starting in a few weeks' time. If they come up in Stevenage or they come up in Rickmansworth, I'm sure, Adrian, I can talk for you that you'd see them in hours as well, even if they're not an in-hours patient. If necessary, if we can't, if the answer hasn't come back quick enough, but it means next morning we have to deal with it. We'd deal with it. But these people need to be treated correctly and quickly.
Scott, can we book them back into a necessary care slot then?
Absolutely.
Yeah.
And you
Okay.
if you've got a cancer patient who, let's say, tonight they're seen and we're not sure what to do, but tomorrow we've found out by tomorrow morning exactly what we need to do for them, we get them in as soon as we can, assuming it's something significant. I mean, not if it's, sensitivity that needs a bit of Durafat, but something more serious needs to be dealt with. Okay. Well, thank you all for coming. If anyone wants to if there's any more questions, I'll take them. But otherwise, we've done the hour. If anyone else wants to hang on and talk about amalgam, I'll be interested to know if anyone's got any thoughts on what to do with this. I'll give you a minute to leave, and then if anyone's still here, we'll chat about that.
Scott, the ones that you've recorded, are they available for anybody else to watch that couldn't make this evening due to work commitments?
I will work out how to share it with people in due course. Yeah.
Okay. All right. Thanks very much, Scott.
Good night, everybody. Here.
Thank you.
Anything else
Bye.
is off the record.